Welcome. Good afternoon and good evening to those of you on the East Coast. As we all are patiently awaiting election results, we're so glad that so many of you could join us today. So again, welcome to the sixth annual Touro University, California Social Justice and Public Health Speaker Series, hosted by the Public Health Program. My name is Gail Cummings, and I am the Program Director for the Public Health Program at Touro University, California. And I, along with Dr. Deirdre Wilson, will be moderating today's session. This year's session and series is titled Public Health in Times of Pandemics, is focusing on two health crises, COVID-19 and the impact of police violence, both of which have collided into a devastating pandemic tandem, and both of which have disproportionate understand and untangle the root causes, implications, intersections, and solutions to these two public health crises. Today's talk is number 5 in our 6-part series. Our presentations have ranged from conversations about inequities and about the clinical impacts of COVID-19 to the root causes of overall health inequities and the political framework and narratives for addressing health and health care from an upstream approach. To our last talk by Dr. Reuben Miller, who took us on a deep dive into the public health impacts of mass supervision among the formerly incarcerated, recognizing the importance of really getting more proximate to this really important injustice, which impacts over 70 million Americans, and how doing so moves our society closer to a more just and equitable and humane society. Now, while I say this about every session, I have to say how extremely excited we are about today's talk, Native American Health and COVID-19, which has been a long time coming. It's also very timely as we're just entering and beginning November, which is American Indian and Alaska Native Heritage Month, which is also another opportunity to focus and learn about diverse cultures, traditions, and the important contributions, histories of Indigenous Americans. It is also an opportune time to educate the general public and raise awareness about the unique challenges that Indigenous people have faced both historically and in the present, and the ways in which tribal citizens have worked to conquer these challenges by shifting narratives and creating policies to build and promote health and social equity. So before we begin with today's session, I'd like to proceed with a land acknowledgement statement. Even though we're still meeting virtually, we still think it's so important because it recognizes that the land itself is not just a space that bodies occupy, and all of us, no matter where we are currently sitting or standing, we all reside on what is Indigenous territory. It also allows for an expression of gratitude and appreciation, as well as a way to honor and understand the history of specific tribal nations. We want to acknowledge that Touro University, California, located on Mare Island, is a site on the traditional land of the coastal Miwoks, the Susunis, and other Patwin peoples, past and present. We honor with gratitude the land itself and the people who have stewarded it throughout generations. Thank you. Now I'd like to turn it over to Professor Deirdre Wilson, Chair of the Community Health for our Action Concentration.
Good evening, everyone. I'm going to echo what Professor Cummings said. We are very excited to present two wonderful speakers to you to provide information and a backdrop about the Native American health and COVID-19. The first speaker we have is Ms. Virginia Hedrick, and then the second speaker we have is Dr. Newland. This session is being recorded, so it is our obligation to let you know our recording policy. Please take a moment to read our recording policy. To our TUC students, this is, of course, a required course for all incoming IMPH students and PA MPH students. You need to attend all sessions using your unique webinar login and complete the speaker evaluations after each session. Today, I will make sure that all of the speaker evaluations are open at the conclusion of today's session. You also have about another 2 weeks to complete The Death Gap by Dr. David Ansel, who will be our final speaker. I already stated that we will have 2 presentations this evening, and at the conclusion of Dr. Newland's presentation, we will have a brief Q&A session. If you have any questions, please type them in the Q&A function at the bottom of your screen, not the chat box. This evening, we're offering CME credits for attending this presentation. If you are interested in CME credits, you must log on during the presentation and complete the form. The continuing education credits are offered through the Touro University College of Osteopathic Medicine and is accredited by the Accreditation Council of Continuing Medical Education. The following screen, the screen has the activity code for today's CME credits. Please log on to www.eeds.com and enter the activity code, which is 28 zone. This information is also in the chat. So if you aren't able to copy this, please look to the chat. For this evening, I'd like to begin by introducing Ms. Virginia Hedrick.
Aikui, thank you, Professor Wilson.
I'm going to formally introduce.
Okay.
Ms. Hedrick is the Executive Director for the Consortium for Urban Indian Health. She is an enrolled member of the Yurok tribe of California and is also of Karuk descent. Her prior work includes chronic disease prevention, implementation, and policy impacts of the Affordable Care Act for California tribes, as well as health research. Ms. Hedrick holds a bachelor's degree of arts in sociology and American Indian studies from the University of California, Los Angeles, and is also has a graduate certificate in maternal and child health and epidemiology from the University of Arizona and a master's of public health degree from Drexel University. If it is not already obvious, Ms. Hedrick comes with a wealth of education and knowledge, but also a personal experience with the Native American health system and Native American tribes. So please welcome me, join me in welcoming Ms. Virginia Hedrick.
Thank you. Aikui, Nakna Virginia Hedrick, Shregon Mewamechuk, Nekpulikla. Hi, my name is Virginia Hedrick. I am a member of the Yurok tribe, as Deidre shared with you, and also of Karuk descent. I was born and raised on the Yurok Reservation in Northern California in Humboldt County. For those in California, you know that that is on the far northwest coast and close to the Oregon border, 1 county away. And live here in Sacramento, California, where I am raising 5 children with my partner. They range in ages from 19 to 4. So this has been a very interesting time in our household as a family as we sort of navigate the new territory of being in a pandemic and sheltering in place and working from home. I am the executive director for the California Consortium for Urban Indian Health. I do have some slides and maybe we'll get to sharing them, but I just really want to thank my colleagues at Touro University for the invitation to be a part of this series. When I think about the terms and positioning ourselves in a conversation around social justice, COVID-19 and it being Native American Heritage Month on the heels and in the midst of ballot counting, it is very interesting times we're living in, very stressful times for many people, and we're all experiencing a bit of pandemic fatigue in one way or the other. And so I want to acknowledge that space a little bit. I know myself have been actively refreshing election result tabs all day, as I'm sure many of you have as well. You know, when we started this pandemic around COVID-19, I immediately started thinking about this impacts to American Indian health. And as we saw the risk factors come out, and I'm sure Dr. Newland will speak to this too, American Indians experience some of the highest rates of asthma, chronic diseases like diabetes, hypertension, that I began to be very worried about what would happen in a situation where we have an infectious disease, that those are the high risk categories. Since we're in all of the context that I framed us in, I think it's really important as an Indigenous person, as a person here from California, that I acknowledge that this is not the first wave of a pandemic that has hit Indigenous people in disproportionate numbers. Since time of contact, since non-Indigenous people to this island, now known as North America, now known as the United States, now known as California, we have been hit with waves of infectious disease. Some of the earliest noted as being that of smallpox, and then later tuberculosis, where Indigenous people were dying at higher rates. It has been noted that in the 1918 pandemic, Indigenous peoples were dying at rates of 6 times that of their white counterparts. So this is not our first time. This is not our first time being impacted by a pandemic. And that's important when we think about, we have to situate COVID-19 through a lens of historical trauma, through being trauma informed, how individuals react to this pandemic, how we move through it, what our protective responses are and what they are not, are really important cultural and historical context for Indigenous people when we start to hear about pandemic, when we start to hear that word pandemic, when we start to hear the words around infectious disease. So I just implore you all to think about that. Think about infectious disease, think about chronic disease in a historical context. Think about them from a culturally humble way. Understand that there are things happening that you may not be aware of, that you may be operating like this is the first time, and we hear a lot of that language. But for Indigenous people, there's something deep in us that creeps up that this is not the first time. This is not the first time an infectious disease has traveled oceans to our territory. This is not the first time that we have seen our people perish at rates higher than our non-Indigenous counterparts. And if you're experiencing fatigue, pandemic fatigue, that what that might be like in a historical context of an individual who has experiences, whose land removals are close, whose land theft are close. When you see news headlines about land and items being looted, and only 160 years ago was your own land looted and then named the capital of a state now called California, you might feel a bit of frustration when you see news headlines with brown people who look just like you, who are being labeled as rioters, who are being labeled as looters, when your history paints a little bit different of a picture. So I know that it's a lot all at once and a lot to unpack, but I wanted to set the stage a little bit and think about a contextual framework for how we have this conversation around what is social justice in the time of COVID-19. How is that absolutely and directly related to police brutality, and what does that look like through an Indigenous lens? I will share my screen as promised. And we'll start from the beginning. I also want to note that I am living, working, and raising children in the Sacramento Valley, which is home to the Miwok people and the Nisenan people, and how important land acknowledgements are. I think we can never let it become such a formality that we forget what in fact we're actually doing. It has long been a cultural practice of Indigenous peoples that when you're in the territory of someone else, you acknowledge that, you ask to be invited into the space, and that you continuously acknowledge yourself as a visitor. That's a practice that was not occurring when non-Indigenous people entered into this continent and into our area. And so reaffirming that visitor status, reaffirming when we are not in our Indigenous homelands is important. It honors the land itself. I gave a talk just yesterday about the land and its importance, and I want to talk about it here too. When we think about healthcare, we have to think about healthcare through the various cultural lenses that it exists. There is one lens that will tell you that health is that of the human body, head to toe, all of the moving parts is how you might take an analysis of an individual's health. Many indigenous cultures would tell you that that's only one measure, that if a person is truly healthy, then you also need to look at the land that they're on. You also need to know about their spiritual health. Where are they seeking spiritual health? Are they balanced? Are their spirits being nourished? And we have to look at mental health. Is there balance in their mental health? Do they have mental health needs? It's really all of these things. It's physical, it's environmental, spiritual, it's mental, and it's community health that really determine the health of a person. Simply taking BMI or blood pressure or A1Cs are not going to really tell you the true health of an individual. And we've been saying this like broken records for hundreds of years, since the beginning of time. But we're seeing it now, and I hope other people see it now, that here in California, as our state has been on fire for years, we see non-Indigenous people saying, hey, these fires have impacts. They're having impacts to our air quality. They're having impacts to our ability to move. They're having economic impacts. And maybe we should take care of this land. Maybe we should think about how we caretake this land. And if you look back about the early writings of some of the impressions of when non-Indigenous people first came into California, they noted that these crazy Indians are always burning the land. Can you believe that they set fires, intentional fires, and they burn this land? Now we call that traditional ecological knowledge. Now we call that a prescribed burn. And now in 2020, we can acknowledge that prescribed burning is a proper way of caretaking the land. And that in fact, our health as humans is directly tied to the land. We can't separate these things. So when we think about infectious health, when we think about something like COVID-19 and how it has socially separated us, how it's physically separated us, we also have to think about that impacts to mental health. We have to think about the impacts to spiritual health and our inability then to gather in our sacred spaces because we know that this infectious disease thrives in that area. So I want you to think about that and what justice looks like when you take all of these pieces into account. What you see on the screen before you is a map of where our 10 members are. We are a statewide alliance of 10 urban Indian organizations. They are in some of California's most populated counties, and many of our cities were federally funded relocation centers where the federal government quite literally bused American Indian people from states like Arizona, states like South Dakota and North Dakota into large metropolitan areas throughout the United States, including San Francisco, Oakland, Los Angeles, and Sacramento as being relocation centers. This is a pre-contact California Indian map of California territories. Everywhere you are in California, everywhere you are in the North American continent, you are in Indian country, you are on indigenous land. So it's these things are not defined by federal reservation borders. These are not defined by being in a high populated area of American Indians or not. This is truly the land we are all on. There are 110 federally recognized tribes in California, with an additional 75 petitioning for federal recognition. That being these tribal folks in the areas of the San Francisco Bay Area, Los Angeles, that there is actually only one tribe that exists that's a federally recognized tribe between San Francisco and Los Angeles, and that is the San Ynez Band of Chumash Indians, and they're in fact not on the coastline, they're in fact in the valley. And there is no mistake about why California's most expensive stretch of land has no federally recognized tribes. Nearly 90% of the American Indian population in California reside in our urban areas or census-defined metropolitan areas. There are more than 700,000 American Indians that identify as American Indian alone or in combination with another race in the state of California. That's more than any other state. There are more federally recognized tribes in California, which is more than any other state with the exception of Alaska, which is home to more than 200 Alaska Native villages and corporations, which have a very distinct different relationship with the federal government. 1 in 7 American Indians and Alaska Natives in California live in a city, and 1 in 9 American Indians in the United States lives in a California city. So where do we live? This map actually tells you a lot about California Indian country and a lot about California Indian healthcare. So I like to call this a heat map, mostly because I'm not a map maker. There's probably a better term for this map. But where the darker color is means that there is a higher concentration of American Indians. I want to point out something that I've been having a conversation with a map maker and that's not even like the right term. Somebody will correct me, I'm sure, in the chat about geographic information specialists, individuals who work in this field, that our highest population by sheer number, when we take the more than 700,000 American Indians that live in California, and we map just those 700,000, this is the map you would see based on concentration. So Los Angeles is home to the most dense population of American Indians. And then you see San Jose, you see San Francisco, Oakland, and Sacramento, Santa Barbara as being sort of hot spots, Bakersfield and Fresno as being concentrated areas of American Indians. This would also overlay really well with just a population density map of California. If you were to map this in a different way, if we were to map it by per capita and sort of overlay the fact of, yes, the highest population of American Indians is in urban areas, as is the highest population of Californians are in urban areas, the map would trend a little different. Actually, in Humboldt County and Del Norte County and Tulare County and Kern County, in Riverside, San Bernardino counties, you would see darker areas per capita, that there is more American Indians living in those per capita based on just those counties. It has been said to me recently that American Indians are the most likely race to live in a rural area in the state of California. The other piece of this map that I want to point out, and maybe hard for some of you all to see, but worth noting, the green triangles indicate tribal health programs. Those are a tribe or a consortium of tribe, a group of tribes who have federally contracted with the Indian Health Service to deliver healthcare to American Indians and Alaska Natives in their areas. The blue stars, which can be difficult to see because they are in these high concentration areas, are urban Indian organizations. And you should have seen that on this map. So just a quick reference, if we click through them, you'll take note of these counties to this map, that our urban Indian organizations are really in the backyards of the highest population of American Indians in the state of California. So what is the Indian healthcare delivery system, and why should we talk about it, and what are the impacts to COVID? We'll get there too, but the federal government has a unique legal relationship with American Indians based on treaties, laws, and Supreme Court decisions, often commonly referred to as federal Indian law. And federal Indian law is its own specialization in law that establishes the trust responsibility. It's often referred to as this trust relationship through legal court cases between American Indian tribes and American Indian individuals who are members of federally recognized tribes, have a political status and a political relationship with both their tribe, their state, and their federal governments. The Indian Health Service is a grossly underfunded system that offers healthcare to American Indians in or near Indian reservations and in urban Indian communities that were either relocation centers through a federal relocation program or just simply have densely populated American Indian communities. The Indian healthcare delivery system is made up of a three-part system. There is the IHS facilities and hospitals. These are federally run facilities that all employees are employees of the federal government, and it's a federal facility. Then you have tribally operated clinics, often referred to as tribal health programs, and they are in a tribes or consortium of tribes are in a legal contract relationship with IHS. The Indian Self-Determination Education and Assistance Act said that tribes have the ability and the authority and the self-determination and sovereignty to contract with the federal government for any service that would otherwise be provided by the federal government, including healthcare, education, enrollment, their own governments. So tribes have the right and authority to contract with the federal government to deliver their own set of healthcare services, partially funded through the Indian Health Service. And then the third tier, which is not last but least, but is funded, last and least, are urban Indian organizations. And urban Indian organizations are run by board of directors that are made up of more than 51% American Indians on the board, and they are in federally designated relocation centers. And urban Indian organizations are a testament to the fact that the federal trust responsibility does not end at the reservation line, that our political status as American Indians is not defined by our living on or in or near a reservation or a rancheria. One key aspect and complexity of the Indian healthcare delivery system is not an insurance program. It is a benefit system. It's not even a benefit system. It's a direct service provider. So if I need to have a checkup, I can go to a tribal health program and I can have a checkup. If at that facility, the doctor determines that I need, or an individual needs some special care, maybe I need to see a podiatrist or an ear, nose, throat specialist, something that's not offered in clinic. While my services provided there at the facility, first I would have to show that I do not have any other form of insurance. If I had private insurance, I would provide that. They would ask me to provide that, and they would attempt to bill my private insurance. Second, they will ask me to apply for Medi-Cal or Medicaid and ensure that I am not covered under Medicaid. By and large, more than 80% of American Indians who are seeking care within the Indian healthcare delivery system are Medicaid eligible. In California, we call that Medi-Cal, so you might hear me slip on that. And then finally, if there is no one else that they could bill my service to, they'll bill me to their Indian Health Service contract. And that is federal law, that the Indian Health Service must be the payer of last resort. This becomes very complicated if I need to have specialty care. If I come into a facility and I am diagnosed with COVID-19 here in California, and I have to be referred to hospital care if I need some sort of specialty care, or I need to be in an inpatient facility, it's unclear then who can pay my bill. It is possible that if I come towards the end of the fiscal year, sometime in May or June, that the tribal health program will have exhausted all of its resources on purchased and referred care and may not be able to pay my visit. If I am not Medicaid eligible and I do not have private insurance, that would leave me with the bill. So I give that example to underscore that the Indian Health Service is not an insurance program. If it is funded appropriately, if we have all of the right funding in place, there's not much for me to worry about. But we're funded in California anywhere from 30 to 40% level of need. And within the Urban Indian Health Organization system, we are not funded anywhere near level of need for the number of American Indian people who need access to services within our territory. So tribal health programs, I've already explained this, are under Public Law 93638, the Indian Self-Determination Education Assistance Act, often referred to as ISDEA, where tribes contract directly with IHS. Many tribes in California are small, and we were the last to be divvied out money from the Indian Health Service. We did not have any Indian health care contracts in the state of California at all until the late 1960s during the civil rights movement. So we cannot separate ourselves from civil rights. We can't separate ourselves from a movement of racial social justice, because this is where American Indians, during this time of civil rights, where we were able to establish in federal law our responsibility to healthcare. It wasn't until 1978 that we had religious freedom, that we could, by law, practice our own religions in the United States without fear of imprisonment. For example, carrying an eagle feather or parts of an eagle are illegal in the United States, which I understand that that's because of an overharvesting of them, not by indigenous people. We had to fight for a law that says we have the right to those. We have a right to be able to have an eagle feather to be able to practice our religions. So for years, for the first 3/4 of my career in Indian health, here in California, there were no Indian Health Service funded facilities in California. In 2017, the IHS opened its first facility in the state of California, and it is the Youth Regional Treatment Facility in Hemet, California. If you're wondering what a Youth Regional Treatment Facility is, it is what it says what it sounds like it is. It is a facility focused on treating substance use disorder for young people 17 years or younger, 17 and a half years or younger. The facility cannot handle high complex cases. They're not able to take any young person that is having suicide ideation or has a multiple co-occurring mental health disorder. That really has to just strictly be a substance use disorder issue. Urban Indian organizations actually have a different authorization. We fall under Title V of the Indian Healthcare Improvement Act, which was permanently reauthorized as a part of the Patient Protection and Affordable Care Act, commonly referred to as the ACA or Obamacare. Indian country is highly attached to the ACA, and many of our funding authorities fall within the Indian Healthcare Improvement Act. Many would say that it's the strong backbone of the Indian healthcare delivery system. So any threat to the ACA or the Obamacare is an absolute and direct threat to the Indian healthcare delivery system. Urban Indian organizations receive one core contract from the Indian Health Service that is intended to be leveraged for other local, state, and federal resources. Many of our Indian organizations, urban Indian organizations, are able to leverage their IHS contract to then become HRSA 330 community health clinics, which is an incredible streaming of revenue. It also means that the urban Indian organization needs to open its doors beyond Indian country and to any individual in need who meets the at-need criteria for HRSA Community Health Center. For those who are not HRSA 330 community health centers, urban Indian organizations are statutorily defined as a federally qualified health center and commonly as an FQHC, and are automatically eligible for enhanced prospective payment system, which is a PPS rate. And we don't need to get into billing, but this means that our urban Indian organizations can bill Medicaid for services provided to Medicaid eligible patients. I'm doing okay here on time, but I realize I'm picking it up because I think I just have about 5 more minutes. I pulled this slide and you saw the color scheme change a little bit. I have been giving almost weekly, in the last few months, it's been bi-weekly Facebook live stream conversations about COVID-19. I started this just 2 days into the pandemic in early March, when I realized that members of the American Indian community were not receiving any direct information, any direct messaging coming from an American Indian person or American Indian organization talking about what a pandemic is. And excuse me, I'm just now seeing the Q&A. I promise I'll get to that. And so I just started doing it, and I was like, I'm just going to have these weekly conversations until somebody, likely someone smarter than me, someone with more pay, someone with more information will come in and start doing these conversations. And that just didn't happen. So I was able to start to bring in my network of individuals. I brought in a very close friend and former roommate of mine who's a physician for a tribal health program to talk about what COVID-19 was, how it worked from a physician's perspective. I brought in the IHS director himself, Michael Wiaki. I brought in a delegate to the Navajo Nation Council, and just various individuals to bring their perspectives over the last 7 months about COVID-19 and to enrich the conversation about how we understood it and how it was playing out. Quickly, a quick piece on data here. And part of my screen is, I'm gonna make that go away. So this is American Indian Alaska Native data reported by California to the CDC. You see that there's a pretty even breakdown between male, female, gender, between COVID-19 positive cases and COVID-19 deaths. This is also the age range. This is not far off, actually, from what you see for non-American Indian Alaska Native data reporting. And I think Anna's going to talk a little bit more about some of this pieces. One piece I wanted to note for you is this great map put out by the California Tribal Epidemiology Center about the tribal state of emergency and shelter-in-place declarations by tribal governments in California. At this point, we have 76 tribes in the state of California who have declared a state of emergency, who may have closed their reservation borders, and have taken other measures related to being in a state of emergency and the COVID crisis. I have stopped my screen share just for a minute to see the Q&As, and I don't know if we're addressing them right now. I think we'll do that in the end. So that's just a little bit of an overview for you about situating ourselves in a culturally humble way, recognizing that healthcare, the definition of healthcare for Indigenous people expands beyond just the one physical body, that we're really talking about community, we're really talking about the health of the public as being a measure of that. And then situating you within what is the Indian healthcare delivery system and what that looks like when we talk about tribal health programs, when we talk about urban Indian organizations, and I know Anne will talk about the federally funded Indian Health Service system as a whole. I do have a few more minutes here, so I wanted to share a few other key pieces about COVID-19, particularly that continue to be a challenge. So when we think about community health, when we think about messaging, and I see it so often, that there's often rises to the top this need to make sure that we have proper language translations. And I'm the first to say absolutely yes. Culturally competent healthcare messaging includes language translations, and we need to have good language translators that are doing an earnest job of making sure that language translations are happening. Because of historical interactions with the federal government and forced removal of Indian children to boarding school, for many Indian people outside of truly the Navajo Nation, English is our first language. And when I think about translating COVID-19 to Indian country here in California, I'm not thinking about language translation from like English to Spanish or English to Tagalog or a different language. I'm thinking about, are we ensuring that we're using culturally competent words? Is what we're saying resonating with Indigenous families? And I want to give you an example of that. Early in this pandemic, when I say we, I mean a lot of things right now. I mean like the public health community. When we said that the best way to keep yourself safe from COVID-19 would be to shelter in place with just your family, and to social distance from all others. For Black and Brown families, that's a lot of people, actually. What public health officials actually meant was your household, with those individuals who live in your household. We didn't actually mean families. We didn't actually mean your mother, your father, your auntie, your uncle, your brother, your sister, unless those individuals live in your household, which for many families, that is true. We live in multi-generational households. But that's not what public health meant. They meant household and not family. And so we have to be careful about, as we do public health messaging, as we do community messaging, that we think about those cultural nuances. How does this translate in a culture that's different than mine? What does this look like? You know, and another data report I'm working on shows that 1 in 5 American Indians live without internet access in their home. So we've created this perfect storm with COVID-19 that you almost have to have internet to thrive and survive in this new pandemic world. We're all here virtually in a Zoom. Maybe some folks have driven to an area where they have internet access. I don't want to assume that that's not the case, but we're meeting in this virtual setting, and there are many Indigenous families who don't have access to this in their home. And so they are either having to go to a community setting or to a family member's house to have that internet access. And how much wider the education gap gets, how much wider the employment gap gets for communities of color who do not have access to internet, and how having access to internet in the home has become a determinant of success, a determinant of our ability to thrive in this new environment. And I could really look at so many indicators, social determinants of health, and say, how has COVID-19 put a spotlight on it? How has it exacerbated that situation? And what does that look like for Indigenous people? And if we're talking about racial equity and you are not including conversations about America's First People, then you're not doing your job. Then you have overlooked an entire population of people who are right here. And it's hard. Sometimes it's hard to make those inroads. There's absolute trust issues, particularly with universities and Indigenous communities who have been over-researched within government systems, and tribal communities who have suffered at the abuse of abusive relationships with the federal government, particularly with health and Indigenous people. So I know I'm throwing a lot at you all to think about, and so many of these things we could dive into much richer conversations on. I just kind of wanted to tease some things out for you all to think about as emerging leaders in your own fields, as leaders in your own fields, about what does an Indigenous perspective look like? What does it look like in terms of COVID-19? What does it look like in terms of social justice? How are you being inclusive or exclusive in your conversations? And who are you inviting to the table? I want to thank you, Professor Wilson and Dr. Cummings, for having me today, and kindly pass it to Dr. Newland, and absolutely here until 6 for everyone else, and can address some of these questions then.
Thank you so much. We really appreciate your insight and all of the information that you've provided for us. And yes, Ms. Hedrick will be available for Q&A, so she'll be here. And so we're going to take questions and answers and provide answers at the end of Dr. Newland's presentation. So if you do have questions, again, put those questions in the Q&A box at the bottom of your screen. I'd now like to introduce Dr. Ann Newland. Dr. Newland is the Chief Executive Officer for an Arizona-based North Country Healthcare. Prior to joining North Country in 2013, Dr. Newland worked for the Indian Health Service on the Navajo Reservation. She trained in internal medicine and pediatrics at the University of Tennessee, Memphis, and served as Chief Resident for Internal Medicine at the University of Tennessee. She later completed a master's degree in public health at the Harvard School of Public Health, and as a Commonwealth Fund fellow in the minority health policy. She also works to improve the quality of care across the North Country system, as well as to make it easier for people to see their primary care providers. So please join me in welcoming Dr. Newland.
Thank you so much, Dr. Wilson. I really appreciate that introduction, and thank you to you and to Dr. Cummings for the invitation to join you all today. As Dr. Wilson mentioned, I work for North Country Healthcare, which is a federally qualified health center with multiple sites across northern Arizona. From end to end, our service area extends 576 miles from Mojave County along the Nevada-California border all the way over to the New Mexico border with the Springerville and Eager communities. I spent 8 years working in the Indian Health Service in Kayenta, Arizona on the Navajo Reservation, and that's where I'd like to begin our story today, because I think we need to ground in a place. I think Virginia has done a great job of giving a very broad overview, placing a context for some of the specific challenges faced in Indian health. But this story is grounded in a particular place at a particular time. And it was my privilege to work in the Kayenta community from 2004 to 2012. This is a picture of El Capitan. It's a diatreme right outside of town. And a diatreme is a volcanic plug. So you'll see these scattered throughout this part of Arizona, and it's part of what makes it so incredibly beautiful. Here's a map of the Navajo Nation as divided into service units. So you'll see in kind of the aqua color up in the upper left-hand corner is the Kayenta service unit. And that's where our story is going to begin. That's where I lived and worked and where I have many professional and personal connections. And if you can find Kayenta on this map, I don't know where you're sitting or how good the resolution on your computer is. If you follow Kayenta out on Highway 160, about 23 miles outside of town, 25 miles, you'll run into a town called Denahotso. That's going to be important a little later in the story. But before you get to Denahotso, you'll see there's a road that's numbered 59 that runs through a tiny little community called Chilchimbito. It's about 70 miles total from Kayenta to Chinle. That's another major service unit in the Navajo Nation. And the road on 59 is particularly beautiful. If you ever have a chance to visit Northern Arizona, I would strongly recommend making that trip. It's one of the loveliest drives there. But the town that we're considering today is Chilchimbito. And it's actually not even really a town. It's more of a census designated area. So a concentration of about 500 people live in Chilchimbito. But this was the site of the super spreader event that began the outbreak of COVID-19 on the Navajo Nation this March. So, you know, most of us in the medical community had been paying attention to stories about SARS-CoV-2 and COVID-19 in January and February of this year. And it was only in March that nationally the United States started to look at clamping down. And I know here in Flagstaff that really only happened probably somewhere around the 15th, a little after the 15th of March. But the incident that I'm concerned about here is a church gathering on March 7th in Chilchimbito at the Church of the Nazarene. They had a day of prayer, and a number of people from across the reservation, particularly in the Western Agency, that's the western half of the reservation, came there for this day of prayer from a number of small communities, from Navajo Mountain up in the north. I'll just go back to this map a second. So if you look up to the north, this area is what they call the Utah Strip. So the Navajo Nation extends into Utah, into New Mexico, as well as here in Arizona. So many people traveled from Navajo Mountain, communities like Lichi, Kaibito, Tonalea, to this small community, Chilchimbito. And these distances aren't so unusual to travel. I mean, people in the north drive a lot of miles. There are people who live in Tuba City who drive to Flagstaff for work, and that's a 70, 80 mile drive. There are people who live in Loop who drive to Flagstaff for work, and again, that's like 50 miles. These are long distances, but it's not uncommon to travel there. So this church gathering was probably less than 50 people, maybe about 40, but it became a super spreader event. So the thought is it was a pastor from out of town that met with folks in a very enclosed area, and dozens of people transmitted COVID-19 to small communities. By 2 weeks later, by the 22nd, 2 people were dead. They'd been found dead at home and hadn't been tested for COVID-19, but the case count was 49 within 2 weeks of that event. And the first cases presented to the Kayenta Health Center, where I used to work. And I think folks really didn't feel like COVID-19 would make it all the way to the reservation. This was so early on in the pandemic that people were caught completely by surprise and did not interpret the symptoms correctly, which led to continued spread of the disease and many early deaths. So this was just a reminder again about the distances involved. You know, Kayenta doesn't have a hospital, so when folks presented to the Kayenta ER, they were sent to Chinle or to Tuba City for inpatient care. Some people, if they were dissatisfied with the initial evaluation they got in Kayenta, drove all the way to Tuba City. And it's important when you think of the hospitals at Tuba City and Chinle, these are small rural hospitals. You know, only about 20 beds total. Under normal circumstances, maybe 6 ICU beds, places where you could have patients intubated. During the pandemic, they doubled or tripled their ICU capacity. But being able to operate an ICU depends on having staff to be able to run the ICU. It takes specialized nursing. It can take respiratory therapy. It takes the physicians, as well as just the physical plant adaptations to do that. So at the peak of the pandemic during March and April, Tuba City and Chinle were intubating 3 to 4 patients a day, which meant that many patients were getting transported away from the reservation for care. Now, that's not so unusual. Usually, a number of patients a day will be transported to a hospital down in the southern part of the state, potentially to Las Vegas, depending on bed availability, or Albuquerque. And usually patients would be transported by a fixed wing transport because most folks could not tolerate a helicopter. So fixed wing is more expensive, but it was necessary to move patients. So this is what one of the hospital units, or one of the medical units at Tuba City looked like back in March. Pretty basic hospital unit. And in March, because they were under such strain to provide services, the National Guard delivered some PPE. And for many things, the staff in these hospitals were left to their own devices to try to figure out PPE solutions. One of the docs helped coordinate homemade Tyvek suits that people would make. And there were calls for all kinds of masks and devices and staff. Because at one point during crisis, half of Tuba City's ER nurses were out with COVID-19. And this is just an example of a field clinic at that time. So coming to today, I'm going to go through a timeline in a little bit and lace in some stories of what has happened. But this is the most recent update of the cases of COVID-19 on the Navajo Nation. And you'll see that it's broken out by those service units, those IHS service units. And this blank area in the middle is not really blank. It's the Hopi Reservation. We won't get into some of the Navajo-Hopi conflicts, but because my experience is more with Navajo, I'll speak to that. I will say that amongst on the Hopi Reservation, they've had about 500 cases of COVID-19, big contrast to what's on the Navajo Reservation. So this is a snapshot from April of 2020. On the left here, we have a map of Arizona, and that's showing cases by county. So the Navajo Reservation resides partly in Coconino County here, and that's where I live, in a town called Flagstaff. Also Navajo County and Apache County. You'll see that the case numbers here are pretty high, almost 1,000 here in Coconino back in May, 1,500 approximately in Navajo County, 1,100 in Apache County. And this is Maricopa County. I know we're all talking about Maricopa as part of the election, but Maricopa is the most populous county in Arizona. So at that time in May, Maricopa had 7,835 cases. But what if we controlled for the size of the population? That's what I'm showing here in this map of Arizona on the right. By looking at the rate per 100,000 population, we see that Maricopa, even though they have the greatest number of cases, the cases per 100,000 is 179. But let's look at what was happening in Coconino, Navajo, and Apache County. 660 per 100,000, 1,200 per 100,000, 1,500 per 100,000. And the contrast with the rest of the state is just so stark. The cases were really concentrated here on the Navajo Reservation. And there was a real drop-off in understanding by the rest of the state about the severity of what was happening in the Navajo community. the Navajo Nation went on lockdown. They imposed a very strict curfew. They imposed rules about how many people could be in stores at a time. And there were videos on Facebook and YouTube at the time of the Navajo Nation president, Jonathan Nez, going to stores like Bashas', that's a grocery store in Tuba City, and encouraging people not to shake hands, to be socially distant. And that's just so anathema to the way people live in those communities. You go to the grocery store so you can run into people and hang out and have a chat and shake hands, and to not shake hands, to not be social, has been very hard in that community. But one of the other things that was very challenging was just to have the rest of the state understand what was going on and how what was happening here could happen in the South as well. I've participated in regional calls throughout the pandemic, regional and now statewide calls, and some are with health leaders and some have been with business leaders. And the conversation early on was all about, well, how can we get back business-wise to doing what we were doing? This is from business leaders in the South who felt like whatever was happening on the Navajo reservation was not relevant to their experience. And, those of us who work with folks with disease, who have a disease, have seen this many times, that people will ascribe the disease to a character flaw. So I remember first talking about the impact of COVID-19 on the reservation with folks, and folks outside the reservation. And they said, oh, well, it's because of obesity. It's because of diabetes rates. And, there's an element of that contributing to the severity of disease, but it's certainly not the whole picture. And it becomes a blame the victim approach to the condition. And at this time, when you look at this number of people who've had COVID-19, this number of diagnosed cases, the deaths from COVID-19 have had a profound impact in these small communities, because everybody knows at least one person, if not more than one, who's died from COVID-19. In July, I just want to contrast how the number of cases grew. So let's look back at May again. Like just under 8,000 cases in Maricopa County. July 30th, we have nearly 115,000 cases. So an explosion of cases in the southern part of the state. And when we show cases per 100,000, the disproportionate impact on the Navajo Nation still holds. Look here at Maricopa County. Their case per 100,000 is about 2,600. But you look at Yuma, Santa Cruz County, that's where Nogales is, and then the Navajo Nation, covering these three counties, it is often close to double the rate that you see in the southern part of the state. And this is an update as of today. So it just underscores the persistent, disproportionate impact of the disease on the counties on the Navajo Nation. Maricopa by far has the most cases, but when you look at it at a rate per 100,000, it's about 3,700 versus 6,000 in Yuma, 3,800 here in Coconino County, and then just under 6,000 in Navajo County, and 5,600 in Apache County. So what are some of the key demographics as we look at those counties? So when we look at the percent of people living in poverty, let's use Arizona's stats as a baseline. 14% of people in Arizona live in poverty, and that's compared to 11.8% of the entire United States. In Coconino, it's 15%. Navajo County, 28.5%. Apache County, 30%. So these are poor counties, progressively poorer counties, and they are also communities of color. So in Coconino County, 27% of our residents are American Indians or Alaska Natives. Navajo County, it's 45%, and Apache County, it's 75%. And this contrasts with the state as a whole of 4.79% American Indian or Alaska Native. Now, Arizona is a state with 21 federally recognized tribes, but the population gets concentrated in a handful of counties. So this is another way to look at the disproportionate impact of COVID-19 in these communities. This is from April of this year. And I listed out what proportion of the cases in each county were from tribal areas. So here in Coconino, back in April, there were 453 cases, of which 324 were from tribal areas. In Navajo County, out of 682 cases, 578 were from tribal communities. And Apache County doesn't really offer clear data, but I would bet that their data would mirror Navajo, and that nearly all of these cases were from tribal communities. When we look at where we are now, this is as of today, out of 5,000 cases here in Coconino County, 5,600, about 1,500 cases are concentrated from tribal areas. Now, a lot of the case growth that we've seen here in Arizona, in Coconino County, has also been related to Northern Arizona University opening up. It's not all the cases, but that's part of the picture. But you look at Navajo County, out of 6,000 plus cases, nearly 4,700 are from tribal areas. And again, the data is a little fuzzier from Apache County. They're a very poor county and underfunded, but I would bet that more than half, easily 3,000, if not more of these cases were from tribal areas, not from the non-tribal areas. So the Navajo Reservation is up here. We have White Mountain Apache that covers parts of these three counties, Gila, Navajo, and Apache, but they're not a major contributor to the case burden. So what have people done? How do you help address this? You know, there's everything from the small things to the large things. I helped source bleach for the public health nurses in Kayenta. We've had different collaborations to get PPE and actual physical help. And Orlinda Tooley is one of our workers with the Ryan White Part B program that actually serves HIV positive patients on the Navajo Reservation. And one part of the problem is that many people live without running water. About 30% of people on the Navajo Nation do not have running water. So one of the things Orlinda and her team did was construct these hand washing stations, and you can see they've got a little foot pump, so you could put water in clean water in the bottom bucket, and then use the foot pump to wash your hands into the receiving bucket at the top, so that families would have a way to wash their hands without a bowl that you might just reuse the same water. So going back to this Black Hawk picture, I use that as a reminder because for many of my friends and colleagues on the Navajo Nation, this is the toughest thing that they have ever had to deal with, and medically in responding to this crisis. And, you know, where I am living and sitting right now in Flagstaff, we've had to work hard, but we haven't had to work like that. The hardest thing I ever had to do professionally was not the COVID-19 crisis. It was when we had to close the Kayenta Emergency Department for a year because of staffing issues. And, you know, we worked through that process. We're able to reopen by contracting out ER services, but that was a move that had an impact on that community. And you think, how do you change this? How do you prevent this sort of thing from ever happening again? How do you prevent the Navajo Nation from having to have Black Hawk helicopters delivering supplies? And one of the side comments that that folks from the National Guard said to staff at Tuba City was that nobody is going to help you. Like, this is it. This is what you get, and you'll have to make the rest of the solution yourselves. So I think the real pathway to changing outcomes, changing health outcomes, and improving health equity is workforce. And there have to be pathways to bring people into healthcare who are trained to work in high-need communities in a culturally sensitive way, and who are from these communities. So some of you may not have heard of something called an Area Health Education Center, but just like FQHCs and urban, tribal, and IHS programs get federal funding, so do AHECs. And it's a way to create greater diversity within the healthcare, within the health professions, and change the way that healthcare is delivered. So that's part of North Country's story. We've had youth programs, health profession support, continuing education as part of our foundation story. So North Country is an FQHC, but it's also an AHEC. And this just gives you an example of the types of programs we've had over the years. And I included contact hours so far this fiscal year versus last year. And what's been impacted the most is some of these youth preparations programs, high school programs, high school enrichment programs. Because kids aren't in school or are attending virtually, we haven't been able to do the clubs like we've done in the past. So we've had only 2,300 hours versus 13,000 hours last year. But what we do in the health professions is help make sure that we train folks in the communities we serve. Oops. And this year we were able to launch a family and community medicine residency that we've named after the Colorado Plateau. And this is part of the Pathways program. So we know that when folks are trained in family medicine in community-based programs, they're more likely to go into primary care. So this refers to Teaching Health Center GME. GME is short for Graduate Medical Education, that's residency. And this is another federal program that helps pay for residency training for physicians. But more people who go through this model go into primary care than in traditional GME. More go to serve underserved areas and rural settings, and a higher proportion go to community health centers. So I will break there. I want to thank you so much for the opportunity to share with you today, and I'd be happy to entertain any questions you might have.
Thank you so much, Dr. Newland, for closing the gap, also just providing information that our students didn't have and introducing them to the health system and gaps that are in the health system to help Native Americans. Excuse me. So we're going to open up our Q&A. So far there are 3 sessions. If you do 3 questions, if you have any questions, please add them to the Q&A and we'll go in the order they're received. One of our participants asked, is it possible for someone to address how telehealth might expand access to care for individuals living on reservations, and what barriers might exist to the implementation?
If you don't mind, I'll take a stab at that, because I live in the world of trying to get broadband access. So Virginia alluded to many folks not having internet access at home. And I would say that for a number of the kids, even in Tuba City, they don't go to a friend's house, they go to the McDonald's because that's where you've got broadband access. So the distances are incredible, and the amount of money it takes to put in the fiber optic lines is incredible. So that's one of the biggest barriers. There's a program called USAC, the Universal Services something. But you basically see a tax on your telephone bill that helps provide funds for rural lines. And part of the USAC program is that the cost for a rural line should not be more than an urban line, and they'll do some price setting to try to make it more affordable. But getting companies to do it is still very challenging. A lot of the health centers do have internet access available. They've been able to get those lines in place. And I know 15 years ago, we piloted telehealth, telepsychiatry at Kayenta. I was really skeptical of it at first, but people embraced it. And even now, folks will try to participate in their groups, but you have to go to the spot where you have the best reception. So you might go where you can climb a hill and you hold your phone up high or do something kind of crazy just so that you can get reception. Or maybe you do that when you drive to Page. But it's a real barrier to care.
Yeah, so echoing what Dr. Newland said, and that there's absolute, digital access barriers. Sequoia has been an advocate for increasing access to telehealth throughout our community health centers and throughout urban Indian organizations. Particularly the ability to bill is a major issue in an underfunded system. So yes, an individual may answer your call and you can provide a behavioral health appointment, but are you going to be able to bill on the back end for that? Are we going to be able to bill Medicaid for that appointment? And COVID-19 has expanded our billing capabilities under this emergency declaration. It's also expanded abilities to prescribe things like medication-assisted treatment. Prescriptions like Suboxone in the state of California can now be prescribed in a telehealth appointment, which is really important, and something we haven't discussed are the other impacts of COVID-19 to substance use disorder, relapse, and an increased use in those who were not in a place of sobriety, along with domestic violence and other. So I would say among our network of programs, in addition to COVID-19 and its health crisis, we're seeing a huge rise in calls for access to mental health, behavioral health, and domestic violence services. And I've had a number of clinics report for the first time ever 100% days of no-shows for telehealth behavioral health appointments. So the need is absolutely there. So it's really unusual to have 100% day of a no-show in BH. And it's so incredible to see that when telehealth is extended in that manner, that people will show up for that appointment. And I think though the barriers are different and sometimes different in an urban setting than a rural setting. So here in the city, sometimes it's 2 and 3 buses to get to your clinic to make it to your appointment, and you've got to make all those transfers to make it there. In rural areas, there's other issues to making it to the healthcare facility. I can share. Where I grew up was very rural. I grew up without electricity, without phones, on an Indian reservation here in California, and fondly remember more than 2-hour van rides to our tribal health program, where really this van just drives through the community, picks up everyone who needs to see the doctor that day, and at 12 you get to ride the van by yourself. And getting $10 from my parents, and good luck at the dentist. When we think about that kind of healthcare system now, I would never let my 11-year-old get on a van and drive, be gone all day. But that's a reality in Indian health. I used to get on this little van and drive to my dentist appointment, and then you just have to wait. You have to wait till everyone on the van has been seen. All their needs are taken care of, any outstanding prescriptions to be picked up, and then we got to stop at McDonald's and Kmart, and it was really fun. And so it was a special day to get to have a dentist appointment and make a trip to town. So these are like realities that though the barriers are different, and I saw in the chat, absolutely in the urban settings with homeless patients who also don't have stable phone lines or those private spaces to take that behavioral health appointment. And you do see that in overcrowded homes and multi-generational homes. I'm telling you, in my own house, my kids are looking for like quiet corners to take their classes. I think we can all sort of imagine what some of those other issues might be.
Thank you so much. We also have another question. It says, as a DO MPH student, I always wonder how best to juggle the community versus individual needs in times like these. How have you delegated your time during this pandemic, and what recommendations do you have for future doctors or public health professionals?
So I think as a doctor, your first responsibility is taking care of individuals. That's your main training, and then you learn to take care of communities. And it's that taking care of individuals that gives you legitimacy to speak to the needs of community. I recently had to reread the Plague. We had a book club, a community book club, and there was a line that really stood out to me. Somebody was asking, the doctor in this book, how do you know what you know? And he said, it's suffering. It's witnessing human suffering. And as a physician, we're privileged to enter that space with an individual, to get to view the world differently. You learn the world differently when you hear their stories. And I personally now have toggled more to taking care of communities. I actually stopped seeing patients in November. That was like a really hard decision, but how do you do some of these other bigger, broader things when you're pulled to take care of patients? And if you're really early in your career, I'd encourage you to just focus on patients, and then the community will come. And that gives you a platform. Like one of the stories I didn't tell, I mentioned that community Denahotso a little farther down the road from the road where you turn off to Chilchimbito. And a friend of mine lives out there with her mother. Her mother was a patient of mine for many, many years, but we still chat, we're still connected. And her mom's on oxygen. But during the big crunch of the pandemic, the group would not deliver, the company would not deliver oxygen to the Navajo reservation. They were expecting Jay to drive to Flagstaff. This is like 140, 150 miles round trip to pick up oxygen tanks. And then they'd limit the number of oxygen tanks she could take. And being able to tell those stories in the right spaces can help change minds, because they don't, so many people who don't have that direct contact with people who are living under these types of constraints and honestly living under the burden of racism, it's not real to them. So you can be in a position to make that experience more real.
Yeah. Thank you, Dr. Newland. I think that was a really great answer. One of the things that I always say to MPH students right now is, and forgive me because this is going to sound so off, but what an incredible time to be studying public health and getting a degree in public health. I think we all have those affirming moments in our life where you're like, this happened and this is why I'm on my path, and I see I'm on the right path because this is happening. So the pandemic is your affirmation that we need more individuals with backgrounds in public health and with public health lenses, really in all spaces, right? We need doctors with that public health perspective. And I think to that point of seeing your patient as a member of a community, right? And knowing, I think when you work in Indian country, you know that if a mother is getting sick, the potential ripple effects that would happen. Who is she? You need to know, who is she? Is she a care provider? Does she have multi-generations living in her home? You need to know more about this individual than just who she is to you as a patient provider, right? You need to know, in infectious disease, what are all those ripple effects that this person, what happens if this person goes down? If this person is hospitalized, who then watches the children? Are they a single parent? Do they have an elder and a grandparent living in the home? Like, I think in Indian country, almost inherently individual health is community health, because it's such a tight network of people that individuals, particularly in rural areas, if any of you live in rural area, you know how much you rely on your neighbors for information. In times of emergency, you're not getting the news, you're relying on your neighbor to let you know that something is happening. So it's a really tight network in that way. And then, the other thing that I would just say is we have so many, you know, there's always that terminology like armchair lawyer. We have so many armchair public health professionals, right? Who are just like, I was on the website and I read this. And what is our dutiful responsibility as public health professionals to break that down for community, to dispel myths, and what it will look like for those of you who are going through a Master's in Public Health program 10 years from now when you have lived experience having been a student during this time. Because right now, so many people are leaning on, well, an infectious disease of MERS, of SARS, which it's almost not even a good place to refer to anymore because this pandemic is so far beyond that. We're referring back to the 1918 pandemic, which none of us have lived through. So that's an interesting point. Some things around stigma, right? And we see this in small communities of stigmatization of COVID-19 and individuals not feeling safe to say that they're COVID-19 positive for various reasons of individuals thinking poorly on them. There are religious beliefs for some communities and some Indian cultures around getting sick, and that to be sick is a sign of bad luck. It's a sign of bad medicine. And so generally, you do see in Indian country people not wanting to share when they're sick, and to be praying and looking for balance in other ways outside of traditional forms of medicine. And, you know, and my work around community messaging has been centered around, we don't own this virus. We need to disown this virus in Indian country, stop feeling ashamed of it and start talking about it. Because if we all secretly have it and we're not sharing it, one, there's this idea that no one has it. No one I know has it. We see that like generally too. But then we're also not doing good contact tracing either. So I know that was like around about a lot of through the question in other areas, but those are my thoughts on that.
That was a really great answer. We have, it looks like, one last question from a prospective MPH student who states that they have experience seeing the devastation of COVID on the Navajo Nation and plans to practice in the community after graduation. So what are some ways that the medical professionals can provide access to care more readily to the reservation? And would something like a mobile clinic be effective instead of having patients drive long distances to access care?
Well, speaking directly about Navajo, a lot of the service units do have mobile clinics, and they're leveraged oftentimes for dental services. I think Tuba City has like a half dozen different mobile units. They aren't all operational at the same time, because the thing about mobile units is they always need repairs. But usually there's a unit that will go out to Lichi. Some have even come down here to Flagstaff because Tuba has a a clinic here in Flagstaff as well, and serves some students at the Kinlani dorms. So I think mobile units are helpful, but you have to think of where do they go? Where are people congregating? And many people, at least on the Navajo reservation, live at dispersed homesteads. And when I used to oversee the TB program, like the health techs who would go out, they would put like literally 1,500 miles on their vehicles a month, because of the distances they were driving to visit individuals. And this wasn't even that many individuals. It might be 20. So if you can imagine how many miles per individual over the course of a month. So you still have to find places where people gather, whether that's the chapter house or a larger community.
Yeah, that's just what I was going to say. Same to Dr. Newland is in some of these really rural, widespread areas, you're not pulling it into a town of people, right? It's like one house over here off a few miles off the main road, and then one. So it's pretty different than like pulling into South Sacramento and saying like, we're going to be at this cross of this street and everybody meet us here. Because even if you go, and it does help, I'm not diminishing mobile services at all. It does help to go closer to community, but it's a real challenge in the Indian healthcare delivery system on a whole. And one of the reasons, and I I failed to mention this earlier. One of the reasons we don't have a hospital in California is American Indian people are dispersed throughout the entire state. So where would we put a hospital? And then what would it be? Would it just be an emergent care center where individuals then are life flighted in? How often would that occur? And should we not just be would we be driving past public and private hospitals to make it to an IHS funded hospital when there are other hospitals to go? Should we not just be advocating for an increase to the purchase and referred care line item so individuals can get care at their closest and nearest source of care in terms of hospitalization and emergent situations?
Thank you for that. I'm not seeing another question in the chat, but I do have a question. Dr. Newland, you talked about it a little bit, but one of the threads that have been consistent throughout all of our sessions this term is the idea and the importance of getting proximate to issues in order to really understand them. So as you kind of talked about that with clinicians and what that looks like. And that is actually something that is not something that public health professionals generally do. Obviously, you know, we look at the numbers and the bigger picture, but I understand and think that is so significant. And so I'm really looking at you, Virginia, to maybe speak a little bit about that and what that looks like for public health professionals, particularly those that are interested in Indigenous health.
Yeah, I mean, I think it starts with that cultural humility and understanding what you don't know, right? I think there's a popular term around cultural competence, which I think is a little arrogant. I mean, I wouldn't say I'm culturally competent in all Indigenous cultures. There are a few I could probably walk you through really well, but I've never lived in Navajo, and I know there are really specific cultural nuances in Navajo, and so I would enter that circumstance in a very humble way, right? So I think to listen to community, and that's different. That's a different perspective than sometimes we're taught as professionals that we have the answers and we're here to deliver answers to community. And that becomes really evident in a number of types of communities that you're in, right? So when I was focusing on my MPH, I actually had a extreme interest in sex workers, and I wrote a bunch of papers on them, mostly because it was this whole realm I hadn't delved into. And public health workers were going out to sex workers and saying, here's all the things you need. And when they stopped to ask, what do you need? It was, stop giving us bags of condoms. Where am I going to put that? Where do you want me to store all of those? I have this small bag. I just need a couple, and I need a place where I can stop and get more. So like real world, and I know it's like a funky example to give, but sometimes it does mean immersing yourself in an Indian community and finding out what are the issues. Maybe people like to ride the van. So what can we do on the van ride? Maybe that's a sense of community gathering for them. You know, that was my trip to town. How can we make that experience better? Maybe they can get more healthcare services while they're in the facility. It's about stopping and listening and being more careful, because we see a problem doesn't mean that that's the same way the community sees it. Those would be some of my recommendations. You don't have to necessarily be a member of a community to have an empathetic ear and to be compassionate to community needs.
Thank you so much for that. I really appreciate it. And I also want to leave some time if either of you have any closing statements or comments that you'd like to give. We have a couple more minutes.
I would just pick up on something Virginia said a little bit ago about how tight-knit rural communities are. And, you know, I know 7 people who've died from COVID-19, and that meant it was my former next door neighbor when I lived in Kayenta. She was the head of the medical records department, an ER nurse who had just retired and who came back to work because she wanted to serve her community. Special education teachers, you know, these are people, these are lives that that meant so much, not just to their families, but to the whole community. And the ripple effects of those losses are profound. And a friend of mine works in it used to be called contract health. I don't know what they're
Purchase
calling
and referred care.
Thank you.
There
But basically, that's anybody you refer out. And Perlisa said at one time they were just sending people out and getting bodies back, and just that they cried every day. So when I see those numbers, they're not numbers. It's the profound sorrow that is affecting that community, and that's just what I would leave you with. The loss, it's just so tremendous.
Thank you for that. And we do actually have one more question. And normally I would just let this go, but I think this is a really important question that we haven't had a chance to really chat about. But the question is, can you speak about what's going on with pregnant women in COVID care? Are they being taken, or is there a system that's in place?
That's a good question. I know if they're at the hospital, they're separated, because COVID positive doesn't necessarily mean that they're super sick. But I don't know, like in terms of people getting sicker, what's happened. I know what was happening at one of the hospitals in New Mexico. I don't want to say the name because I'll probably get it wrong. That they were separating babies from Native moms early on, because they were assuming that moms were COVID positive. And I think there's been enough of a backlash that they're not separating newborns from their moms, even if mom is COVID positive. But I don't know if anybody else knows more detail.
Okay.
Yeah, I can tell you that in general, American Indian women have some of the lowest rates of accessing prenatal care. This is like pre-pandemic. In California, I spent about 3 years working with the State Department on producing an American Indian focused MCH report. And if this is any indicator of like the kind of data gaps we have, it took us years to produce a report. And we were challenging things like, so in California, you have the American Healthy Infant AHI. It's the AHI survey. Every baby that's born in the state of California is generally included a sample of this. And the only babies that were counted in California as being an Indian baby, and point of reference here, I use the term Indian. It's a cultural term for me. It's my grandmother was labeled as an Indian person. We are Indian people. She actually often equated being Indian with being Yurok. I one time, she met friends of mine and she said, "Oh yeah, your grandfather didn't even speak Indian." And I said, well, "I thought he spoke fluent Kaduk." And she goes, "Oh yeah, well he did." So they're like, "Wow, you guys are so Yurok centric that like no other tribe counts as being Indian." But so that's my natural term I go to. It is also how we're labeled in federal Indian law. It's not culturally appropriate necessarily for those members outside of the community to use the term Indian. It's what I use. You'll hear American Indian, Native American, and specific tribal references, and you should be following those guidelines. Back to my point, the only babies that were counted as being Indian were babies whose mothers were Indian. So if the father was Indian, the race of the father was not counted in determining the race of the baby. If the mother was American Indian and another race, the race of the baby was not counted as Indian. So we had this very small sample set of Indian babies in this first sample. It was only 1,200 babies were included. Really actually a small number to do anything statistically significant on low birth weights, sudden infant death syndrome, like really hard to say anything about that kind of sample size. But when you use an all-inclusive definition, and when you say that baby is Indian if the mother is Indian alone or in combination with another race, and that baby is Indian if the father is Indian alone or in combination with another race, the sample size went up to 17,000. And we could say something important. And we said really important things, that in fact, Indian babies were dying at rates of SIDS higher than any other race in California. And that while other communities seem to benefit from back to sleep campaigns and public education campaigns, Indian babies in the state of California did not. We stayed pretty stable rate of sudden infant death syndrome. We found that we are breastfeeding for longer and more exclusively than other races, an incredible strength of the community to celebrate. We found that we are least likely to access prenatal care, and that we are most often accessing prenatal care in late second and third trimester. So I have a lot of concerns about what we'll know about prenatal care in pregnant Indigenous women post-pandemic. I think everyone is so focused on I'm hearing an echo. I'm hearing myself. Anyone else hearing that?
You're fine, at least
Okay.
on my end.
Okay. So I can't answer your question. I think it's a really interesting point. Maternal child health is like my back burner passion project I never get any time to work on. And I think it's something we'll all look at in the years to come, is what happened to pregnant women. I also think that there may be some positive outcomes of women being home during this time, of babies being home exclusively during this time, and there we might see something interesting. We might see increased breastfeeding rates. We might see baby bonding, other kinds of things that might have positive influences on things that we don't know a lot about, like sudden infant death syndrome.
And I'm just looking at the, it's a chat. One of the participants is saying, because of Spanish colonization, many of us also have Spanish surnames and get misidentified as Latino Hispanic. So thank you, Kim. And I want to thank Dr. Newland and Virginia Hedrick. This has been so informative. This is, again, winding down to one of our last sessions. This is, as I mentioned, a long time coming. I want to appreciate one of our colleagues and partners from Touro University, Kim DeCampo, who's been really helpful in helping us drive and move forward some of the sessions that we want to take place, and we look forward to continuing partnership with our partners right here in Vallejo, California. And we want to make sure that we extend, and she's continuing to put more information in the chat. So please look at our chat. And we appreciate all of you for joining us. We know this has been quite an emotional roller coaster of a week, and understand that we are all going to probably be going to our computers and our newspapers and televisions to find out what's happening with the election. So again, this has been really informative, and we look forward to having you return, hopefully, at our session again next year. So thank you. Have a good evening, all of you. And our next session is November 19th with Dr. David Ansel. Thanks again.